Hello everyone. It's my fourth lecture related to the anatomy of the pancreas, or in Arabic pancreas, or in Japanese suizo. So in Japanese pancreas is suizo. If we say pancreatic artery, suidomyako, pancreatic vein, suijomyako, pancreatic duct, suika. As you see here is just images for the pancreas here isolated from body. This image shows the inner structure of the pancreas, where you can see the ducts here, main pancreatic duct. Here this image shows pancreas. It's cut here to show you what's behind it, like splenic vein here, spiromesenteric artery here, and portal vein. Of course, stomach is lifted up. So learning objectives for pancreas, you have to know the external morphology, parts of the pancreas, and position, of course, and the relationships. You have to also know the blood supply and the nervous supply and the lymphatic supply and the related clinical anatomy. Here is the image for pancreas in situ. As you see here, here is the C-shaped duodenum, and here is the spleen. Here, the pancreas is retroperitoneal organ, which start from the concavity of the C-shaped duodenum until the tail of until the spleen here. It is formed of head, neck, body, and tail. The head here is related to the duodenum, close contact with the C-shaped duodenum, and it has a process called uncinate process. This one. Of course, if you look to this image, the stomach is cut here, so it means the stomach is anterior to the pancreas, because the pancreas forms part of the stomach bit. Here is the various parts of the pancreas here. So if you look here, here is a posterior abdominal wall. Here is a posterior abdominal wall here, and here is a C-shaped duodenum, and again here is a various parts of pancreas. Here is the head, which contain uncinate process. Here is neck, body, and tail. As I mentioned before, it is pancreas is retroperitoneal organ, means it's covered by peritoneum except the tail, which is related to the splenic hilum, and which is enclosed within the splenorenal ligament or Rhinorenal ligament. Spleen is yellowish, or you can say salmon pink color, and it's lobulated. It's about 15 centimeter and is located in the epigastric and left hypochondrial region. And as I mentioned, it forms part of stomach bed. Here, just I want to show you the posterior relations of this pancreas. As you will see here, here is the head, and here is the uncinate process. Here is the, if you look to the head, what is posterior to the head here, and important to know, is this green colored structure, which is common bile duct, or CBD, common bile duct. CBD. It is passing behind the head. You can see head proper. This part is called head proper because this part of the head is called uncinate process. So a common bile duct passes behind the head or head proper, and where it meets the main pancreatic duct here, this one, main pancreatic duct, and both together form one duct here called hepatopancreatic duct, which open here in the jejunum. So structures behind the head proper of pancreas, main pancreatic duct here, and also the common bile duct and hepatopancreatic duct. What's behind the neck here? The neck is the junction between head and the body. So means behind the neck is the junction of splenic vein coming from the spleen and superior mesenteric vein to form the portal vein. So behind the neck is the portal vein. Actually, it's formed by fusion of splenic vein and superior mesenteric vein, like in this image. If you look here, here is we cut here at the neck of pancreas, cut here. So you can see here the splenic vein, and here is the superior mesenteric vein uniting together, forming the portal vein behind the neck of pancreas. So this means that the neck of pancreas is related posterior to the portal vein and its formation by splenic vein and superior mesenteric vein. Behind the body of pancreas, you can see many structures on the posterior abdominal wall. For example, you can see the superior mesenteric vein, superior mesenteric artery. Here is the vein and the artery here. You can find the abdominal aorta. Also, you can find some muscles here on the posterior abdominal wall, like psoas major muscle here. You can also find some blood vessels, as I mentioned now, abdominal aorta and superior mesenteric vessels. That's important structures deep to the body of pancreas. The tail of pancreas is within the splenorenal ligament, and it is associated with the splenic vessels. If you look to the pancreas here, you found the pancreas here has upper border here, and it has anterior border and it has lower border. I will show you this in the next slide. So here is the pancreas again, isolated. Here uncinate process, here head proper, here is neck, here is body, here is tail. So what's anterior to the body of pancreas? Here you can find the body of the stomach. You can find the antrum of the stomach. Okay, you can find pylorus here. What is anterior to the head of pancreas? You can find colon, part of the colon here, and also part of the, you can see the colon, part of the colon, and of course transverse colon crossing here, and also here you can find the loops of small intestine anterior. So that's anterior relationship. So anterior to the body of pancreas, you can find the stomach, and separating the body of pancreas from the stomach is the omental bursa or lesser sac. The uncinate process here is related or anteriorly crossed by superior mesenteric artery and superior mesenteric vein. That's important relationship. If you look here to the uncinate process, I will show you next slide maybe. Yeah, here. Here is the uncinate process. It's crossed anteriorly by superior mesenteric vein and superior mesenteric artery. So uncinate process here is embryologically and anatomically different from the head proper. What else here? I mentioned here clinical anatomy because, as I told you, the head of pancreas is related posterior to the common bile duct. Here is the common bile duct. Okay? So if there is tumor in the head of pancreas, it will compress the common bile duct and induce what's called obstructive jaundice. Obstructive jaundice. If there is tumor at the uncinate process, it may obstruct the here is the uncinate process here. If there is tumor here, it may obstruct the duodenum and induce duodenal obstruction. Also, because the superior mesenteric vein is closely related to the uncinate process, so if there is tumor also here, it may compress the superior mesenteric vein. If you look to the neck here, I told you behind the neck there is portal vein. Portal vein. So if there is tumor in the neck of pancreas, it may compress the portal vein and induce portal vein obstruction and portal hypertension. The pancreas is coma-shaped, as you see here, and it has three surfaces. I mean, the body of pancreas has three surfaces, anterior, posterior, and inferior, and three borders, superior, inferior, and anterior border. Attached to the anterior border of pancreas, there is a transverse mesocolon. When you make cross-section here, it is the cross-section is triangular with three borders and three surfaces. If I ask you which artery is along the upper border of pancreas or superior border of pancreas, you can say the artery is the splenic artery, which is tortuous here. If I ask you which vein is deep to the body of pancreas, the vein is the splenic vein. Splenic vein. So that's important relationships. And also, as I mentioned, the tail of pancreas is enclosed within ligament here. This ligament is called the Rhinorenal Ligament. So during splenectomy, this ligament may be damaged. And of course, this ligament can be divided, and then we remove the spleen by splenectomy. As in case of, for example, splenomegaly or hemolytic anemia, we remove this usually the spleen. So we have to divide the ligament, splenorenal ligament. So we have to avoid injury of the tail of pancreas because it's located within this ligament. You can read this sentence by yourself. Here here is a CT of the showing the pancreas, and also this is cross sections at different levels. So here at the level of uncinate process. So here is the uncinate process. So what's anterior to the anterior? Here is anterior, and here is posterior. Here is vertebra. So maybe it's lumbar vertebra, maybe L1. So here is the uncinate process. What's anterior to it? Superior mesenteric artery and vein. What's posterior to uncinate process? You can find inferior vena cava. You can find abdominal aorta. Okay. You can find also gonadal vessels. So if there is tumor of uncinate process here, it may compress this. It may compress the superior mesenteric vein. It may compress the inferior vena cava, and that's a big problem because it will induce vena caval obstruction. Here is a cut section at the level of neck of pancreas. Neck. So here is the neck. So what's behind the neck is the splenic vein and also the superior mesenteric vein, where they unite together, forming the portal vein. So from here is a splenic vein here, and here is the superior mesenteric vein, and here is the splenic veins unite together, forming the portal vein. So the neck is junction between the head antibody. And behind this junction, the junction of superior mesenteric vein and splenic vein forming the portal vein, and also pyloroduodenal junction is anterior to the neck. Pyloroduodenal junction is anterior to the neck of pancreas. Here is the cross-section at the level of tail of pancreas. Here is the tail. So what's behind that? Here is the tail. You can find here is the splenic vein here, and you can find also the splenic artery. Splenic artery should be above here, okay, above the body of pancreas. Here is the CT. You can find here is the level of, here is the head of, here is the uncinate process. Here is the head of pancreas. You can say head proper. Here is the splenic vein, and here is the portal vein, which is, and here is, but superior mesenteric vein, you can also, superior mesenteric vein is not shown here, okay? That's CT of pancreas, and of course there is the tail of pancreas. I think this is the kidney, left kidney, and also here is the spleen. Here is the spleen, here is the right kidney, here is the liver. Here is the abdominal aorta. What's here? It is dissection of the pancreas, which shows the various parts of the pancreas. So here is the duodenum here, C-shaped duodenum. Here is the uncinate process of pancreas. It's not shown because it's crossed by superior mesenteric vein and superior mesenteric artery. Here is the vein and here is the artery. Here is the neck of pancreas here. So here is the portal vein, and here is the body of pancreas. Here is the tail of pancreas. Here is the spleen. Here is a slide showing the structures within or inner structure of pancreas. Inside the pancreas here, there is main pancreatic duct here. This is main pancreatic duct. And here is the common bile duct, which pass deep to the head of pancreas and unite together here, forming hepatopancreatic duct, which is dilated in this part in what's called hepatopancreatic ampulla. And this hepatopancreatic ampulla open here in the second part of duodenum, open at the major duodenal papilla. Above the major duodenal papilla is minor duodenal papilla, which receive the accessory pancreatic duct. This is one. That's all. So here is the diagram. Here is the duodenum here, of course. So here is the duodenum, okay, and here is the gallbladder here. Here is the gallbladder. So here is the cystic duct, which unite with the common hepatic duct, forming as a common bile duct here. So here is the cystic duct, CD. Here is the common hepatic duct. Here is the common bile duct, which unite with the main pancreatic duct or MEBD, which forming the hepatopancreatic duct, which open here at the MEDB or major duodenal papilla. That's all. Here again, here is showing surface anatomy. As you see here is here is the levels of the vertebrae from T12 to L4. As you see, generally the pancreas is located at level of L1, but the head, the uncinate process looks like at the level of L2, okay? And the tail of pancreas looks like above L1, between T12 and L1. As you see here again, here is the main pancreatic duct. We call it duct of Wirsong, or here is the duct of Wirsong or main pancreatic duct, and here is the accessory pancreatic duct or duct of Santorini. I think 1, 2, 3, 4 is the various parts of the duodenum. First part, second part, third part, and fourth part. I think that's enough. here is dissection of the pancreas. As you see, here is the tail, here is the body, here is the head, and of course here is, but it's not clear here, is the uncinate process, which is crossed by superior mesenteric vein and superior mesenteric artery. Here is the main pancreatic duct here. Here is the gallbladder. Here is the cystic duct. Here is the common hepatic duct. Here is the common bile duct, which pass deep to the head of pancreas or within the head of pancreas. So if there is tumor here again in the head of pancreas, it may compress the common bile duct and the patient will suffer from obstructive jaundice. Here is isolated pancreas and isolated second part of the duodenum. So as you see here, here is the tail, here is the body, here is the head. Here is the main pancreatic duct or Versong duct, and here is this one, main pancreatic duct, and here is the accessory pancreatic duct, and here is the opening, which is here major duodenal papilla, and above here there is minor duodenal papilla around, maybe around here. Next. Here is diagram which show again what I mentioned now. So here is again the common bile duct. Here is the main pancreatic duct here, and here is the fusion here, forming hepatopancreatic duct, which is dilated part here called hepatopancreatic ampulla, which open here in the middle of second part of duodenum at the major duodenal papilla. Here is MRCP, magnetic resonance cholangiopancreatography, and showing the gallbladder, cystic duct. Here is the right hepatic duct, here is the left hepatic duct, here is the common hepatic duct. The common hepatic duct unite with the cystic duct, forming the common bile duct, and the common bile duct unite with the main pancreatic duct here, and open here in the major duodenal papillae of the here is the duodenum second part. Here is technique called ERCP. ERCP, endoscopic retrograde cholangiopancreatography, which is used which is combination of endoscopy and fluoroscopy. We inject dye through this endoscopy to this dye enters the major duodenal papilla here. This dye enters the bile duct and enters the main pancreatic duct. And in this case, we can visualize the duct system here. We can visualize the common bile duct. We can visualize the main pancreatic duct. If there is tumor here, we can detect this tumor by this method, ERCP, or endoscopic retrograde cholangiopancreatography. Also, we can do, if there is a stone, for example, here, stone from gallbladder and descend down to the common bile duct here, we can remove this stone using this technique. Here is the posterior view of the head of pancreas here, and you can see here is the duodenum. So here is the celiac trunk. You can see here is the blood supply of the pancreas here. You see here is the artery supplying the head of pancreas here and duodenum. One is called superior pancreatico-duodenal artery. Superior pancreatico-duodenal artery is branch from this one, this superior pancreatico-duodenal artery, which is branch from gastroduodenal artery. This one, gastroduodenal, gives rise to superior pancreatico-duodenal artery. And there's another branch called inferior pancreatico-duodenal artery, which is branch from superior mesenteric. So there is anastomosis between superior pancreatico-duodenal artery and inferior pancreatico-duodenal artery in this area. And this anastomosis is supplying the head of pancreas, of course, and the duodenum also. Here is again, there is maneuver called Kohar maneuver, where here is anterior view, where we reflect the head of pancreas laterally. We call it Cocharization, Kohar maneuver, and this procedure we use it if we want to access the right kidney here, for example, and there is a stone in the ureter or kidney, we have to remove we have to reflect the head of pancreas lateral medially towards the left side, after removal of subperitoneum, which covers this part of the pancreas, of course, and also we reflect the duodenum to expose this the kidney and also the ureter. As you see from this anterior view, you can see here is the common bile duct here, and also you can see here is the inferior vena cava, so we can displace so that's posterior surface of the pancreas, posterior surface, and the anterior surface from the other side. So we show here is anterior view of the IVC or inferior vena cava and also of the kidney, but in the same condition, this is posterior surface of the pancreas or the head of pancreas, and you can see the common bile duct here. What else here? You can test yourself, so you can see what is this, what is this, what is this, what I want to tell. You can, that's anterior view, so that's the I will tell you hand. Here is the stomach, okay? Here is the left kidney, here is the right kidney, here is the spleen. You can know you by yourself what is this group of vessels or structures, what is this big vein, what is this big artery, what is this vein, and what is this vein. You can do it. Arterial supply of pancreas, I already mentioned it. The head is supplied by, as I mentioned, by superior and inferior pancreatic, here superior and inferior pancreatic duodenal arteries. The body of pancreas is supplied by branches from the splenic artery. We call it pancreatic branches of the splenic artery. I think that's enough. Regarding the venous drainage of the pancreas is drained by two veins, of course, by superior and inferior pancreatic duodenal veins, which drain into the portal vein directly or indirectly, and also it's drained by pancreatic veins, which are drained to the splenic vein. So it means the drainage of the pancreas is finally to the portal vein. Nerve supply of pancreas and the lymphatic drainage. The lymph nodes supplying the pancreas is related to blood vessels. So here is the splenic lymph nodes, and here is the gastrosplenic lymph nodes. Here is the suprapancreatic lymph nodes. Here is the infrapancreatic lymph nodes above and below the pancreas. Here is another group, and this lymph node finally drain into the here is the celiac lymph nodes, and finally to the cisterna, chyle, and thoracic duct. Here is the nerve supply. Is the nerve supply of pancreas either from parasympathetic, from vagus nerve, and it is stimulate the exocrine secretion, because the pancreas has exocrine function and endocrine function. Exocrine function is related to secretion of pancreatic enzymes, which is stimulated by vagus nerve or the parasympathetic innervation from vagus nerve. It has also sympathetic supply from T6 to 10 spinal nerves via splanchnic nerves. Okay, and also the celiac plexus, which contain both sympathetic and parasympathetic fibers. Pain fibers to the pancreas is carried with the sympathetic innervation, and it goes to the thoracic dermatomes from 6 to 10, as I mentioned here above here. And sympathetic fibers as vasoconstrictor. Here is the development of pancreas. Maybe you will know about it in embryology later on, but just remember that the pancreas during embryonic life, it has ventral, there is ventral pancreatic bud and dorsal pancreatic bud, and then both there is rotation of this one, of the ventral, and unite with the ventral, making the here is the pancreas here. During this rotation, this ventral bud may compress the duodenum and inducing what's called annular pancreas, which compress the duodenum and inducing intestinal obstruction. Here is this very important slide which shows image which show that gallbladder stones may migrate down here to cystic duct and then go to the common bile duct. If the gallbladder stone stop here at the common bile duct, there is obstructive jaundice because bile cannot go down to the duodenum. If the stone go here and obstruct the hepatopancreatic duct here, so there will be obstructive jaundice and also pancreatic enzymes will not pass to the duodenum. So there will also be a kind of reflux of pancreatic enzyme here, and the patient will suffer from acute pancreatitis. So that's very important to know that stone in the common bile duct may induce obstructive jaundice there, and also stone in the main hepatopancreatic duct or ampulla may induce both obstructive jaundice and pancreatitis. I think that's enough, and thank you very much. Bye-bye.